Okay, I am going to start slowly, but Deborah, I don't know if you want to introduce this first.
Hold on a second, sorry.
That's okay.
No, I just want to welcome everybody. Thank you for signing up. I think we are expecting a few more. This is a monthly series designed for families and friends who have individuals, loved ones, who are challenged with mental illness. We have different topics, as you probably saw from our flyer, each month. We did an introductory session last month, and this month we're focusing on depression and mood disorders. And our presenter this evening works for Continuum of Care. Her name is Rista Luna, and she will give you her background. She's immensely qualified and very engaged and involved in topics. So I am going to turn it over to you, Rista, and thank you again.
Sure. So my name is Rista. I am the family coordinator for Continuum of Care, specifically CRS. This is a relatively new role for me. For most of my career, I have done crisis work and admissions work and insurance authorization work. But recently, as I get older, I've been choosing to have more of a clinical role in the program and in life in general. And one of my passions is to work with families because I think there's most of the time neglected in the therapeutic process in most institutions, right? Like everyone focuses on your identified patient and what services they need, but sometimes you have questions that are not answered, concerns that you don't know what to do with, feelings that you don't know how to process. And I think it's important to have families for families to have a forum where they can learn and share these experiences. So having said that, this is a long presentation. Please let me know if I'm going too fast. I am addressing two things today. And I want to obviously make this interactive and have time to have questions, concern, comments, and for you guys to share your experience so that we can all benefit from it. So let's start with depression. Most of you, as this being one of the most common diagnoses in the mental health field, most of you have identified depression as the first thing that you notice in your loved one as a symptom. I am trying to get this to work, so hold on just 1 second. I'm trying to get my slideshow to do what I want. Okay, here we are. Okay. Major depression, however, it's more than the blues. And when I say this, I mean, we all have experienced depression that is circumstantial to life. We lose someone, we lose a relationship, we don't get the job that we wanted. We all know the symptoms of depression in that sense. We've all experienced some circumstantial depression sometime in our life. Major depression, the diagnosis of major depression has a strong biological component. And it's more than just what happened to me or what didn't happen to me that is making me feel sad. One of the main characteristics of depression is, of course, feeling sad and blue, but sometimes you might have asked yourself, my loved one has everything is going well for them. Why is he or she feeling this way? They have so many things going for them. Why is he or she not interested in anything? Why is he or she not thriving like, I was hoping they would? It is because there is more than just the blues that this says. There are biological indicators of a major depression episode that sort of mark the difference in between just being depressed about something and having a biological depression. When a psychiatrist diagnoses depression, they usually say, what are the neurovegetative symptoms of depression? And that means that, sorry, I now have to go down on there. Okay, what are the major symptoms of depression? And that means basically, what are the biological indicators that this depression is more than just the blues? And those biological symptoms are very clear. So there is a change on appetite, either decreased appetite or increased appetite. Sometimes you notice it's change on weight. And that is a good indicator that there is a mood disorder going on. There is what they call anhedonia, or losing of interest of any kind of previous enjoyed activity, which is sometimes hard to see because we find our loved one all of a sudden not wanting to do their favorite thing or not wanting to engage on the thing that they enjoy the most in life. There is changes on the sleep patterns, which is also a very important neurovegetative symptom of depression. Sleeping too much, sleeping out of cycle. People sleeps all day and it's awake all night. Or sleeping too little, cannot go to sleep, has a hard time falling asleep, and sleeps 2 hours and it's wide awake again. And this might, the one thing that is important to know is this might not happen the same way all the time. If you've had a person with many major depressive episodes, you might observe all of these things in the different ways that it presents. And then the feeling of tiredness or fatigue, which basically means that, or what the psychiatrists would call anergia, no energy, right? Like even though they spend most of the day in bed, they have no energy to do anything. Everything is a task. Brushing your teeth, getting new clothes, taking a shower can become a task for someone who's quite depressed. In terms of a major depressive episode, and you might have even heard your loved ones say these things, sometimes the verbalization of thoughts of guilt that are most of the time not correlated with reality. Feeling guilty that they've done something unforgivable or something that will land them in jail or will, that's really, really punishable. Something that, again, cannot be solved. And usually that's the precursor or is associated with suicidal ideation. Having trouble concentrating, thinking or making decisions, that's another key component of a major depressive episode. If you've ever interacted with someone that is depressed, sometimes making the decision about getting out of bed takes like the whole morning. Making the decision about, anything that to you might sound trivial, it's a big deal for someone that is depressed. And again, the suicidal ideation that is associated to these like irrational thoughts comes into effect. They call it the common cold of mental illness because most of us have experienced depression in one way or the other. It is very common. In your lifetime, if you're a woman, there's a 20% chance that you will experience depression. If you're a man, there's a 12% chance that you will experience depression. And then if you have an episode of major depression, chances are you will have another one. And it affects severely the life of the person suffering from depression. And again, you guys have experienced that this probably with a lot of your family members, when you are depressed, other aspects of your life are affected. Your social circle reduces, your relationships with the closest people to you get severely affected. You lose your job or cannot continue being in school, have to take a leave of absence. It is really debilitating and life-changing for most people. And if you consider that being depressed already makes you feel very, very bad about yourself, having these losses as a consequence of your depression makes it even harder to deal with your symptoms. As I said in here, that depression has been described as the leading cause of disability in the United States and in many other developing countries. And again, it is more disabling than we can at first sight think. We usually think about disability when we think about the major psychotic disorders, and if we get a diagnosis of depression, we might think, oh, this is not terrible. At least my family member is not having a primary psychotic illness, and yet it's probably the most disabling illness among the psychiatric disorders. Okay, what causes depression? Again, there is a combination of factors, as with most mental illnesses. There is psychosocial stressors that can cause depression. Tensions in different relationships, some major setbacks in life, inability to communicate with others. But there is a very strong biological component to depression, and there is also a very strong genetic component to depression. Let me go to the risk of suicide. This is the big concern about depression, and I wanted to put it up here because it is something to talk about. There's a lot of research about suicidal ideation. There is a lot of people with plenty of resources for people that have suicidal ideation, for the family members of people with suicidal ideation. There is a lot of resources and a lot of research. And one of the best things that I've seen lately in the research about suicidal ideation is how important family involvement and how important asking questions about this is. So people consider suicide by many reasons. They can be just unhappy about their lives, and the main component of this unhappiness is not only that I am unhappy because I didn't get the job, or I lost someone important to me, but that I become hopeless. And by that, I mean that there's no solution to my problem. Whatever I did has no remedy, right? I ruined this relationship and I cannot fix it. I ruined my life because I did this, and now I'm not going to be able to accomplish this or this other thing that I wanted to do. I ruined, I'm getting old and I'm not going to be able to go to the college that I wanted to go. I neglected my relationship with the love of my life, and I now, like, that person has moved on. There is and it might or might not be true, but there is an element of I cannot fix this. There is some engagement in reckless behaviors, like I said here, jumping off a tall building or believing that you have special powers. But the most important part, even if you are not grandiose about the action that you're doing, is the impaired judgment. There is this inability to think like we would think in a normal situation. So people with depression ends up doing things that might get them in trouble with the law, that might really break these relationships, that might really, really alter their lives, right? You've seen people with depression end up, of course, in emergency rooms, end up, in restraints, end up, in pickles because their judgment was so impaired. Some of the depression and mood disorders have or can have a psychotic component to them. So sometimes if they're hearing voices or there is a psychotic component to the depressive illness, that further impairs the judgment, and that further impairs their ability to have control over their actions. Very concerning, especially, is someone that is having command auditory hallucinations, and that means basically voices telling them what to do. When there are true hallucinations, people feel that they have to do what those voices are telling them. And that makes it really, really hard to not, to exercise any kind of judgment, to exercise any kind of control over those impulses. And then there is the fact that some people just doesn't ask for help. And, maybe they're not even trying to kill themselves when they do something to stop the pain or to to make things better for themselves, and they end up dying unintentionally. And that's very important because a lot of people talks about, oh, this is attention seeking. This person is just like, it's a cry for help. And it could be, right? But if we don't pay attention to the attention seeking, or we don't hear the cry for help, it is possible that accidentally that person might end up dead. Especially for clinicians, that's always something to remind yourself as a person in this field. I always tell myself that even though I have to behaviorally address the attention-seeking behavior or the cry for help behavior, I always have to pay attention to make sure that my client is still alive. And again, that is something that that is providers or institutions like Zero Suicide or the American Academy of Suicidology are recommending that families do learn about this as well, so that they can provide interventions and simply ask questions. And I think we're going to move on into that soon. Here are the red flags. Changes in the level of depression. That is a big red flag. Sometimes you see that your family member is getting better and it's more animated. And in the past couple, like they were super depressed, and in the past couple of days, they have a little bit more of energy. That's a red flag. Sometimes you're too depressed to act on any of your suicidal thoughts or thoughts of self-harm. Once you get a little bit more of energy, then you have enough energy to act on those. So increase, actually someone that is flatline depressed is not as scary as someone that all of a sudden gets a bump up on the energy, because that means now they have more energy to do what they were thinking about. So that's a big red flag. Definitely having a specific plan. And sometimes, we hear these things that, oh, if I were to kill myself, I'll do it this way. That's a fantasy. But when people tells you, I am not, I want to do this in this day, for example, that's a red flag, right? That is an indication that this person is thinking about when they're going to do it and even how they're going to do it. So a specific plan is always something that will raise a red flag for us too. Having access to ways to kill yourself. And I know that in this life, it's really, really hard to not have access to things. But there is a training that is provided for the community in general, but it's provided for the families of veterans and families of police officers, for example. It's a CALM training. And that basically, educates about how having access to firearms just makes it easier for you to kill yourself. So if you have someone that normally is allowed to carry a weapon, it's, there is all these interventions designed to remove that weapon from their possession until their suicidal ideation and their depression is addressed. But it's the same thing, the same education that we can provide for you as families. For example, if you are to bring your family member back home, how are we going to manage the medications, right? Sometimes having blister packets so they don't have access to all the medications at once is a way to prevent access to medications. Sometimes having a lockbox that requires some work to get into, even if the client ends up ultimately getting access to the lockbox, having to come and ask for the key, having to, go through certain steps, makes those medications more accessible. Talking about your concerns with your psychiatrist, there are medications that are more lethal than others, right? And weighing pros and cons about what medications my family member is on. Their medications, and they're relatively harmless in terms of being able to cause death. I used to work at another hospital, and people that were like having cries for help used to take overdoses on, for example, Seroquel, right? Seroquel, you can take lots of it. It might make you sleepy, but it's not going to kill you. So there's certain medications that are just not lethal. And there are other medications that are over the counter that can have a big effect on and be lethal, right? Like Tylenol. A certain level of Tylenol will like basically impair your ability to coagulate and be lethal. So learning those things, making sure that those things are away when my family member is if my family member is where it's to be home with me. You know, making sure that we are educated about how to not have access to these things. And again, we'll go into this in a little bit, always asking. Feelings of worthlessness, again, it's associated with the helplessness, right? If I cannot do anything to fix anything, if I'm not worth anything, then my motivation to be here decreases. Talking about unforgivable behavior, we talked about that this unreasonable guilt, this I've done something that it just cannot be fixed, hopelessness, and again, the voices, especially when they're of command nature, because there's this feeling of lack of control. So I think we talked about these two. There's a strong genetic component with mood disorders in general that causes a level of imbalance in the brain, and it puts our family member at a disadvantage. One of the groups that I run in the program is about medications and how they work in your brain, and the clients like it a lot because it makes it very clear that it's not their fault to be to have these symptoms, to be depressed, that just their brain for some reason can just not keep that basic neurotransmitter in the what they call the intersynaptic space, and if that neurotransmitter is not there, there's no message of happiness to be transmitted. So that medication, usually the SSRIs or SNRIs, are the ones that allow for those neurotransmitters to stay there longer, so that the message can happen, so that the brain cells can communicate to each other this message of well-being and comfort. But if that doesn't exist in there, there's no message to transmit. So that's very, very important to understand, and to understand how medications work, and why do you see sometimes these changes that are like day and night once they start a medication that works for them. And there are other medications that are depressive, like benzodiazepines can exacerbate depression sometimes because they act as even though they work very well in anxiety and they're very calming, they're also very depressive, right? Like they increase your sleep, they decrease your energy, the symptoms that they produce are very similar to the symptoms of depression. So they could exacerbate depressive symptoms. And of course, alcohol and drugs, again, some of them are actually also depressants. Most young people does not realize that drinking alcohol is actually drinking a depressive drug. They tend to see more of an anxiety controlling kind of drug, right? Like it makes me more social, it makes me more able to do things, but it also makes me more depressed because of the same reason that a benzodiazepine could, mimic the symptoms of depression. Okay, this is the fun part. And we do this with clients, and a lot of crisis programs do this with clients. I will send you some material that is not here if you're more interested about learning about this. But a CRP, a crisis response plan, it's a very good tool, and it's a tool that can be taught and can be learned by people that are not clinicians. And it can be done by clients once they're in a better situation. So this is not done with a client when they're in the emergency room or in the hospital, or when they're still like fairly acute. But once they're coming off their depression, this is a good thing to do, and it helps you as a family member or as a loved one, help them, and it helps them remember what works. I've done it with when I've had clients, I've done it with them, and it's fun to see them have this click with them. So we ask 4 questions. What are your warning signs? And it's the question. The question can be like, how were you feeling the last time you felt like you wanted to die, right? How were you feeling before your last suicide attempt? And they'll usually tell you, right? Like, in the example on the right. I was crying, I was getting angry, I wanted to hit things, I was having arguments. Very common, state of mind when you are in crisis. So, okay, so that's how you look like when you are in crisis. That's how you look like right before you want to attend in your life. Let's write it down so you know that when you're looking that way, you need to do something about it. Okay, and then the next question is, what can you do on your own to get out of this state? What can you do without any help? What things work for you without having to ask anyone to help you? And I can go for a walk. I can engage on an activity that I like. Just a lot of our clients is like, well, painting or doing art helps me. Journaling helps me. Doing games on my phone. It's listening to music. Okay, no one needs to help you with that. You can do that on your own. And then the next question is, what if that doesn't work? What if like doing all these things that you can do on your own are not helping you? What can some other people do for you? What can your friends do for you? What can your family do for you? What can your therapist? And then you identify who those people are. So in this case, I can talk to Bill. I suppose Bill is his friend. I can talk to my psychiatrist. I can call the hotline. I can, go to the hospital. And then the most important, the fourth question is like, what are your reasons for living? Write them down so you can look at them. So you find the motivation to do those things that you can do on your own and you can do with others. And again, when they are in a better place, when they're not in the moment of crisis, they will tell you why they want to be here. These little things are written usually in a card like this, in an index card like this. Some of them, especially these days, they can take a picture and have it on their phone as their background. Some of them paste it behind on the phone and carry them with them. They can give you a copy. So if you're living with them, you can be like, oh, I see you're crying. It says here that when you're crying, you might be having a hard time. Do you want to try going for a walk? Have you talked to Bill, right? So that way you know what works, and you can feel effective yourself when you are when you're doing this. And if anything, honestly, the fact that that you can do this more confidently will tell the person that is in despair, know that there's someone that wants them here, which is ultimately the idea, right? Like the idea is to be able to ask the questions. I see you're crying. I see you're angry. I think you just threw the door, or you just broke that. Is this a sign that you need help? Can you do something on your own? These are the things that you said you can do on your own. No, I can't. None of that work. Okay. Do you want to call your doctor? Do you want to call your friend? It says here that helps, right? Just having those things might make the difference in between someone going farther with a suicide attempt or being able to reset. And it's, these illnesses are grave. They're difficult to manage sometimes for us and for our family member, but this tool does work. I've seen it work. I've seen it work more than once. I've seen it work with my clients here at the program, right? Once they develop their CRP, instead of me having to come running every time there's a crisis, I can say, do you have your CRP? What are the things that you can do for yourself? Who did you call today? What staff member did you go to today? Because they have had the time to think about it, and they have had the time to identify the things that work. And if it doesn't work, you can write a different CRP. Let's say you wrote your first CRP and you said that you were going to color and you tried to color and you felt worse. Erase that from that plan. Add something new that worked, right? And that's another question to constantly ask, you know, what works? If that didn't work, what would work instead? And the other tool that is available, and again, I'll send this to you guys for you to explore, but this tool is the CSSRS, and it was developed by Columbia University, and they have all sorts of different tools within the CSSRS to use in different settings. There's free training online, and this tool has been adapted so family and friends can use it. And they're very simple questions. Are you feeling suicidal? Do you have a plan? When was the last, you know, for how long have you been feeling suicidal? And basically, if you ask those 3 questions, it gives you a nice rating. If the rating, and it's actually for families, if it's even color coordinator. If you're in the yellow, there's suggestions what to do with your yellow. If you're in the red, there's suggestions what to do with the red. And if you're in the green, you know, it's okay. And you compare it with this CRP, meaning you can say, okay, if you're in the red, you're going to use this tool, this part of your CRP. If you're in the yellow, you're going to use this part of your CRP. So it's a way, there are tools that can help you feel safer asking questions, knowing that this is evidence-based, knowing that someone has done research and it's proven that works. We use this Columbia all the time here. Like just, you know, and we teach it to our staff so that even staff that are not necessarily clinical can ask those questions, because again, asking the questions does make a difference. So I'm going to pause here before I go into the bipolar illness part of the presentation. But it'll be nice to hear from you and your experiences with your family members' depressions, and you know, again, how has it affected your relationship with them, and how do you feel about talking about suicidal ideation with your loved one? And you can also put the questions in the chat if you guys feel more comfortable with that format. Or you can unmute if you prefer that. I'll try my best, Liz. So that is the Columbia Suicide Screening. Screening.
Severity.
Yeah. Oh, severity screening. Yeah.
Reading. Yeah.
And CRP is crisis response plan. And as I said, go ahead, Sue.
I was just going to say, I find the most difficult part about my son's depression is that his coping mechanism of using the alcohol, that I think has given more of a difficulty with us than I almost feel like if it was just the depression alone, we could handle the situation to a certain extent and help him a lot more. But I think it's the alcohol use or whatever else other people might use as a coping mechanism is very difficult to deal with.
Yeah, yeah,
Um,
and especially because sometimes, like we were saying, right, like the substance abuse, which is an attempt to self-medicate, ends up exacerbating symptoms and making them a lot worse than they were.
Yep.
And yeah, I mean there. And once you add another problem to the presentation, meaning now this becomes a pattern, you know, and that's like a go-to coping mechanism,
Yep.
becomes more difficult to actually, you know, create new neural pathways in your brain so you can use something different.
Yeah, and he doesn't see it as an issue because he gets some kind of uplift out of it temporarily as it is. But that's, you know,
Yeah, yeah,
dual,
no,
dual diagnosis of the addiction and the depression is very difficult.
yeah, definitely. And I would say it's hard to address one or the other separately. We do have a presentation in the near future about co-occurring disorders that can be, I can go more into detail about how to address both in parallel, but it's imperative that you address both at the same time. Because if you address the addiction and do not pay attention to the depression or the bipolar illness, then that's definitely going to come out, right? Meaning that especially if that's the primary illness, if that's how it started, right? But if you address the depression and you don't address the addiction, then again, the coping mechanism is never going to change. So it's a very delicate situation. What I can tell you is that once you can find new neural pathways, once you can find new ways to effectively use coping skills, the not so useful coping skill, meaning the alcohol or the drug, becomes less crucial. So you might have a dual diagnosis client that for a longer time talks about fantasizes with drugs and glorifies them and thinks that they're like the best solution to the problem, right? But as long as they don't have to use it, as long as they don't have to use it as a coping mechanism, the more chance that you're giving them. And that's in part, you know, in higher levels of care than ours. Some people needs to be on a higher level of care for a longer period of time to not have to use, right? Some people has to be on a protected environment for a longer time to not have to resource to that substance. But it's also, you know, the better, and I know like some of your family members especially have a depression that is kind of even treatment resistant. So it's hard to say that it will be addressed just by a simple medication change, right? But once it's addressed with a more integrated intervention, the least need for that substance. But they go hand in hand. You can't say that that you by addressing the depression, you will fix the substance use, and you can't say that by addressing the substance use will fix the mood disorder. Yeah. There's also a lot of psychoeducation that we do and needs to be done with these young people because they're going for this self-medication. Sometimes it's in hopes of feeling better, and it doesn't work, right? But like you said, there's this temporary euphoria caused by the substance that gives an illusion that maybe this time I'll feel better, only to end up where they end up.
Yes.
All right. For the sake of time, I'm going to move on. But if you guys
hold on
have,
a second. I think Tanya had her hand up.
oh, Tanya, please.
Hi, I don't want to take up too much time, but I just wanted to respond to, you know, how this impacts us, or I think that was the question. And one of the things that I feel we have experienced, besides the sense of immense helplessness and fear and worry and all those things that legitimately others must feel, is that we don't broach the conversation because we try to keep things light and leave like the care team to take, the conversation to where it's going. But were we to be able to have like a conversation with our daughter, there are a million questions we want to ask and know. And at the same time, we refrain from asking, to the point that we haven't really talked about it for a very, very long time. Like, why would you do it? What are you thinking? Well, like, we so stay away from anything that might trigger something in her. So I think what's hard is, if you take the sense of helplessness on our part and the fear, and also like human need to have like questions answered as data collectors. And maybe the data collecting is like self-preserving to be able to process our own fears. Like if we know like more information, maybe we'll feel better. I think that's part of like why there is this sense of need to know, but we don't discuss it. And we often are feeling like, should we or shouldn't we? And I think, Rista, I've said this to you before, to me, like it's like a game of Jenga where you just don't know which part you're going to pull out that's going to, everything will fall apart.
And I think we've had some conversations, and I've always go with like, keep it light, keep it simple. And I think these tools, the CRP and the CSSRS, allow you to do that. You're asking, I think it's important to ask, because sometimes depressed people want someone to ask them. Someone wants to, so depressed people wants to know that someone actually cares and wants to know if they're feeling suicidal or not. So the question is okay. The depth of the question, I think, is managed well by the CSSRS or by the CRP, because those are very simple tools. And it's just a simple question. Are you feeling suicidal today? Right? And then with the CRP, what of the things that you already know help can you use to feel better? Can, like, without, again, violating confidentiality, I know with your daughter, do you want to play guitar? Do you want to talk? Do you want to have some time to yourself? Do you, what of the things that work for you can you do on your own? Do you need someone else? Do we need to tell someone? Do we need to tell your therapist? Do we need to, what of these tools that you already know work for you can you use? Because we want you to be here, right? Because not so much going into like, how did this happen? When did this happen? Why are you thinking like, that's too much for them to process. And a depressed brain, again, has to conserve energy, right? So, because they don't have that much of it. So a depressed brain only hears simple things. What can you do yourself? What can I do? What can someone other than you do? And those things, keeping them simple, might make a difference. And again, my main point with this is, don't be afraid to ask the question, but use these guidelines, which are very simple questions, to ask the questions effectively. Yes, I will give you the Columbia link and the CRP link as well, Liz. But yes, it's very difficult to do this if you don't feel confident. So in part, that's why I'm gonna try to give you these tools so that you can be familiar with them. And if you wanna, during future family meetings, practice a little how to ask them or ask questions. We can do that too. The idea is to empower you to be able to use these tools effectively. All right, let's go to bipolar illness or mood disorders. Let me just look at my time. Okay, if we don't finish, we can always retake this the next time. But we'll try our best. So what's a mood disorder? This involves not just depression, but large mood swings. And some of your family members might have started with a depressive episode and then, had maybe an episode of irritability or even of phlegmania that might have changed the diagnosis into a mood disorder. And mood disorders have, there are many mood disorders, but once depression is accompanied by a different mood, by either mania, hypomania, or irritability, then we're now talking about a mood disorder, not just depression. The other thing that is important to know is that most of your family members are relatively young, and mood disorders do not show themselves fully until at least 25, 26. Before that, you are looking at a presentation on time, meaning this is how your family member looks now. Next episode might look different. Usually brains are mature or complete their maturation by age 25-ish. So by then, you most likely you will have seen everything that there is to know about your family member mood disorder. But before that, you might be surprised every time symptoms show. And like depression, they affect, every aspect of your family member life. Bipolar 1, it's when there's been a episode of mania. So actually, psychiatrists diagnose bipolar 1, even if there is no episode of depression or hypomania. If your family member had an episode of mania, and that's grandiosity, psychosis, decreased need for sleep, increased goal-directed activity, they feel like Superman, really. They can do anything and everything. They, spend hours in like different projects. If your family member has had one episode of mania, even if there has not been an episode of depression, that will be sufficient for a diagnosis of bipolar 1. Most people with bipolar 1 will have both manic episodes and depressive episodes. And bipolar 2, it's more difficult to diagnose because the mood dysregulation associated with elevation is not as prominent, but it can be equally difficult and cause a lot of trouble and disability for your family member. So to diagnose bipolar 2, you have to have a hypomanic episode and an episode of depression. And for that diagnosis, you need both. And a hypomanic episode might be very difficult to recognize. Sometimes it's associated, it's like basically a mini mania, right? The symptoms of hypomania are not as pronounced as mania, but again, there's a little bit of grandiosity, a more goal-directed activity, more agitation. So, that's to a certain extent easy to see. It's like you kind of look not like your normal self, but sometimes a hypomanic episode can be characterized by irritability. And that's the most difficult to recognize. And sometimes, we just don't even associate that with another side of depression, right? But that's when your family member can become aggressive. That's when your family member can become, out of character mean to you, or out of character, I don't know, episodes of road rage, episodes of aggression towards partners, episodes of, again, increase, aggressive behavior. It's, when you think about suicidal ideation, you think about aggressive behavior targeted towards inwards, right? When you think hypomania or hypomanic irritability, you think aggressive behavior targeted outside. And that, as I said, that might be more difficult to recognize because you're just seeing someone being mean or elevated, angry, right? But not necessarily mania. So these are the symptoms of mania. I'm gonna I already sort of described them. I will go to the next slide. And then hypomania is basically the same symptoms, but at a lesser stress, at a lesser extent, or with a shorter duration. But also, again, it's not uncommon to see hypomania as mostly irritability. What causes bipolar disorder? Again, loss of genetics with this. There's neurotransmitter imbalances, just like with depression. But there is genetic and familial theories that do, sort of point out to a strong family component. Sorry. Okay. First degree relatives have 4 to 6 times higher the chance of getting bipolar illness than the average population. So if you do have someone that in your family that has been diagnosed with bipolar illness, and then your family member is diagnosed with bipolar illness, there's likely a familial component on that. The good news is that if you have someone in your family that has bipolar illness and has responded well to a good medication regime, and that medication regime works for them and they're stable for years, chances are that medication regime will work also for the newly diagnosed client. There is a lot of research, for example, on families of lithium responders, right? If like mom or dad that have bipolar illness is doing well for years on lithium, that psychiatrists will likely choose lithium as a good medication for the newly diagnosed client, because chances are they will be as well a lithium responder. But there's similar research with second generation antipsychotics and even Depakote, which is a anti-seizure medication. So if there's something that has worked for someone, in the family, chances are that might work too for your family member. So that's good to know. Facts about bipolar disorder: approximately 5.7 million American adults are diagnosed with bipolar disorder in any given year. People living with bipolar disorder alternate between periods of depressions and episodes of mania. And again, this might be just one episode of mania, a lot of depression, or a lot of mania and very little depression, but both of those need to be present for the diagnosis. The presentation, as I said, varies with age, especially with young people. The presentation of the bipolar disorder can be different every time it presents, and it likely doesn't look like it's going to look until their brain has matured enough. And then, as you well know, individuals with bipolar illness are definitely at an increased risk of abusing alcohol and drugs. And again, unfortunately, drugs have this mood regulating effect that enamors people with bipolar illness, right? And again, you name it, drugs do have a mood regulating effect. Alcohol has a mood regulating effect. Opiates have a mood regulating effect. Marijuana has a big mood regulating effect. And when you're having bipolar illness, and even cigarettes, right? Like, why do people with mental illness smokes more than people without mental illness? It's cigarettes are actually a mood stabilizer. Nicotine is a mood stabilizer. So, it even if temporarily, and even at a high risk to your health, all these things do feel like they work for these young people. And individuals with bipolar illness especially have a hard time with medication compliance, because sometimes they feel good without meds, right? Because again, up and down, sometimes you go past the middle, right? And when you're in the middle, I'm fine, I don't need medication anymore, until you're like up again or you're down again, and now you're more willing to comply with medication. But that's the problem with bipolar illness, that you're not staying in one place all the time. Sometimes you're down, sometimes you're up, sometimes you're like, okay. And when you're okay, you're like, I don't need anything. So it's important to, again, psychoeducation, it's very, very important for people with bipolar illness. And again, if I open it up for the discussion, and I'm sorry I went too fast, I just wanted to get everything in. But you know, again, what are the most difficult behaviors to manage with bipolar illness? We talked a bit about substance abuse being an aggravating factor, and it really is, and it delays the possibility of recovery for a lot of these young people. And more importantly, have you found yourself anything that works to support these young people? Have you found anything that they've told you maybe this has worked? And it'll be, I mean, I know you all have very similar experiences, so it'll be good to have that discussion. And I'm gonna stop the share so I can look at all of you. And but I have plenty of resources. Liz, do you have your hand up? Oh.
I was just waving hi to Sue
Oh.
because we were the only ones on for a sec. Mute me.
Anyone, any questions, any comments?
No, I haven't found anything that works. I don't mean that, you know, being flippant or anything. I wish I could find something that was, you know, that worked, and but
Yeah, no, it is hard, and it is hard. I do have my own experience, as I share with some of you, with having a young daughter with a mental illness as well. And I know I do definitely hear you, and getting those phone calls, especially when she's back from college now, but getting those phone calls from college when, you know, you're having someone like 12 hours away with suicidal ideation, or not being able to get out of bed are a lot, right? And sometimes you the one thing that has worked, and I've been lucky enough to have an insightful child, is to empower her to find her own solutions. I think the hardest thing I've done in my life is to let her stay in college, where I had all the impulses to go pick her up and be like, you can't be there. But putting it on her to find her own solutions, and that included, you know, like, if you're going to stay in there, you need treatment. You're going to have to find treatment providers. You're going to have to find people that helps you. You're going to have to make it happen, right? And I was lucky enough that worked. Like, you know, find a psychiatrist, find a therapist, which one of your friends it's going to help you, because I'm 12 hours away. And that empowered her, and I think helped her also realize that she had some control over the outcome of her illness. But again, I guess those tools that we're learning today, the CRP and the CSRS, have that goal too, like empowering our clients to make decisions about the interventions that they're going to use with their mental illness. And so sometimes that looks a little bit harsh, right? Because it's like talking to our kid and saying, well, okay, you want these things. What are you going to do to make it happen?
yeah,
Not me, it's you, right? It's you want it, you want to do it your way. How are you going to make it happen?
right.
All right, let me share again for a little bit before we go. All right. I'm going to send you this but there's a bunch of books and that you can read. They're again very very easy to read, and they're designed for caregivers and family. So they'll address some of the questions, and some of them come from a very experiential place. There is also some resources on the web. And I think the site for Lighthouse, which is the big project that developed the CSSRS, is also in this slideshow. And that's it. But I'll send you these, and I'll send you the other resources that I have, so you can have them.
Well,
So we made it to 7:01. So I don't know if anyone has last minute questions. I know Deb just put also some resources on the chat if you want to access them as well.
so, but you're sending us the, what?
I'm sending you the stuff, definitely.
Yeah,
Yes.
my autocorrect makes it really hard to type it. It wants to guess what I'm going to say. So that would be nice.
Yep.
So-
No, I'm definitely sending the stuff.
I don't think that the person that I talk to with you is serious when I talk to him these days. And if we were ever in the throes of something, then I can't get through to him at all. I mean, I guess he's probably listening to me a little bit more to you, but I mean, it's just extremes. I mean, right now he's well, and he's in a good place, but he's kind of too upbeat to, I think, to want to get serious. And then when things decline, he doesn't hold on to doctors. That's, I think, the main thing, maybe, doctors. That could have, it happened to be the last time it was during COVID, but it's happened for years and years.
But
So-
that's the nature of bipolar illness, and the most difficult part about bipolar illness is to gain insight into the bad parts of that, right? Because usually when you're well, you're not experiencing any of that. You're well. So just like, the natural reaction, and think about how you will feel yourself, right? Like usually the natural reaction is to say, well, that happened, 3 months ago. That's not me. That's not going to happen again. Or like, that's because I was, using drugs, or because this happened and I'm not doing that anymore. So and this person now. So it's really, really hard to gain insight.
This, by the way, is allergies, even though I feel like crying. I've been crying for a month, so it's allergies again. So, but these.
But, again, I think not being afraid to ask the questions is very important. And I think like this material that I'm sending you will help you a little bit on how to ask the questions, because at the same time, it's not like asking very, very deep questions, but enough questions. So are you safe? Are you okay? How, those things, what are the things that you can use if that happens again? I know you don't think it's not going to happen again, but what are the things that you can do if that happens? How do we, I'm sure none of your family members wants to be in the hospital again. None of your family members wants 911 called on them again. So how do we make that happen again?
But he just is not receptive to that right now. He's not receptive to answering any of that. How many times can this happen? But because it might be beyond his control.
Yeah.
But so he left behind a book. I'm gonna move eventually. I'm not getting rid of anything, but I'm trying. He left behind a DBT book. Is that something that I should read? Enough places.
DBT is a good technique for emotional regulation. Not necessarily the best recommended treatment for bipolar illness or depression. It's more, I mean, not that you cannot use it, and some of the techniques are universal for many things, but it's more recommended for personality disorders than necessarily for mood disorders. Actually, the best treatment for mood disorders right now, evidence-based, is CBT interventions.
That's
Just
what I thought
our-
I said. That's what I thought I meant to say. I didn't mean DBT. I think I meant cognitive, CBT.
Yeah.
Even though I know there's dialectic and I don't know what that is, but I think I meant to say CBT. I think the book was CBT. So I'm going to take a peek at that. No,
Yeah, CBT might be good to read and understand.
okay.
um,
I
for
didn't mean
most
to say DBT.
No, I mean, DBT is a good technique. It's just like, you cannot use the same technique for everything. So for bipolar illness and depression, the treatment of choice is CBT.
Yeah, okay, and I'm listening. So I thought that when he was in other treatments, and probably including now, if he wasn't reading the material himself, and he was an English major, you'd think he could, but if he isn't reading it himself, it's presented to him, right? Because the most he could ever say to me about it was, it's mindfulness. And that's, and I think it got to be a joke after a while, that was all he was going to say. So, but
Yeah.
is it mindfulness?
It's part of it. It's one of the skills. And sometimes mindfulness actually, we can go into detail, but we're running out of time.
All right.
But yeah, mindfulness is more than just meditating, right? It's an attitude, and it's a way to approach things. And it's part of like one of the techniques that CBT works.
CBT. I didn't mean to say DBT. That's it. Even more confusing to me.
We'll learn anyway.
What?
All right. Well,
All right.
I will
sorry
be
to keep you.
sending all these material. Thanks so much for attending, all of you.
No,
And
thanks for
I
the
hope
long
it was
day.
helpful.
Long day that you do for us. Thank you. That you
No
put in.
problem. You're welcome. Bye-bye.
Bye. Thank you. Bye, Sue.
Bye.
Bye. Steve.